Welcome. It's so funny doing a virtual event. And then thank you all for being here in person so that I actually have someone to look at, right? I'm Shanti Moling, and I live and work in Portland, Oregon. And I do almost exclusively endometriosis excision surgery. I do a little bit of other surgery and care, but it's really mostly about endometriosis. And in that capacity, day in, day out, I'm really face to face with the magnitude of what endometriosis is for patients' lives. So we have this beautiful gift, and I want to thank the AAGL for doing this today, to allow us to put together a group of practitioners, and then we have online advocates and people who are watching on Zoom to participate. So I'm going to go through a little bit, just the basics. I think everyone here, I'd be preaching to the choir, so I won't spend too much time. But the endometriosis basics, we all know endometriosis is a chronic disease worsening over time, particularly if untreated. Worldwide, affecting at least 170 million people, born female, and 10% at least of reproductive aged persons. Delayed diagnosis, on average in the US is nearly 12 years, and that is embarrassingly less than in some of the developed nations. It is not only a disease of the pelvis, but can invade the diaphragm, thorax, gastrointestinal, and urologic systems, as well as some other areas in rare cases. It has a huge impact on quality of life, missed school and work, missed social activities, loss of sexual pleasure, infertility, lost wages, going along with loss of insurance and ability to get care, loss of self-esteem, increased self-doubt, and definitely strained relationships. The real crux of the problem becomes, in part, access to care, confusion of the information that so many of these patients are receiving, medical gaslighting. Patients feel they cannot really trust the medical community because they get misinformation that's different from different providers. And so I thought today that I would choose five providers. One of them's virtual. 5 providers, and we have an advocate who's also actually a provider. But providers who have devoted their lives to this disease and who in a like-minded fashion really are seeking answers. And so they're each going to give a very short talk, because we have an hour, and I want to cover some questions that have been sent in. And then we're also going to include our advocates and let them chime in on some answers to questions. So with that, I'm going to introduce our very first speaker. Her topic is asking the right questions and making informed choices. So I will introduce Dr. Karen Orbach, Iris Karen Orbach. She's often called Dr. Iris. I always call her Iris. She's a fellowship-trained excision surgeon. She's been in practice many years, I think over 20, and she is she's written a book. She'll tell you a little bit about herself, I'm sure, but she is one of the people I admire the most in this community, and so I would love for her to go ahead and speak on her topic. And then we'll switch to Dr. Orbach.
Okay, she has a slide, but I thought it was with yours. Okay.
Let me see.
Yep. You want to show them which one?
I'll grab my computer. You got it? Yeah. Fantastic. I've got a little exercise. It's all good.
While the presentation's loading up, I want to tell all of you what my passion is really patient empowerment. And I really do think that patients are the driving force in change in endometriosis. I think as physicians, We have an intellectual curiosity, but patients are really driving the need for better access to care, for better questions, and for better access to excision of endometriosis. So when Shanti asked me to speak about endometriosis patient empowerment and asking the right questions and making informed choices, I was so excited to share some information. I'm not only an endometriosis excision surgeon, but I'm an endometriosis patient. My daughter has endometriosis, so I kind of see endometriosis from both sides. I am an author, and I'm the founder of Iris Wing Sanctuary for Endometriosis Surgery and Wellness. We're based in Los Angeles. So, you know, my goal for all of you is to know your knowing and know your gut. I know that seems such a simple concept. I think our gut is the brain of the body. And each one of you who's here listening knows the pain that you've been suffering. I could spend about 20 minutes on this slide, but each of you has lived some element of this slide, whether you are a teenager suffering from painful periods, whether you've seen countless gynecologists, multiple gastroenterologists, maybe you've been referred to a psychiatrist because the pain is quote unquote in your head, seen a rheumatologist, suffered with infertility, had an ablation surgery or 2 or 3 until you finally found your answers with an excision surgeon. You know your knowing, you know your pain better than your physician. So when you step into that office, I want you to step in that office with a place of power to really advocate for yourself. This is my goal. My goal is all of you, if you're suffering as a teenager, for us to pick up endometriosis very early on. And that's why I do what I do. So when you're searching for a surgeon and you want to know, is this surgeon the right one for me? I think it's very easy for us endometriosis patients to just want to go right to the core and figure out, are you the excision surgeon for me? But I think if we start with a little softer questioning and asking the surgeons, what percentage of your practice is delivering babies? If they say 50%, you really don't want them as your surgeon. And then if they say a smaller percentage of obstetrics or no obstetrics, you want to ask them, how many days do you operate each month? If they say, I have 1 day of OR a month, well, they probably aren't the right surgeon, but then you want to further query them, of that 1 day a month, how many of those surgeries are laparoscopies? And of those, how many are endometriosis? And instead of asking them, do you do excision, say, what's your preference? Do you do ablation or excision? And then hopefully they answer excision, and you probably want to ask them, how many specimens do you typically send to pathology? And I think that's really important because all of us who are in the field of endometriosis, there's a lot of surgeons who claim to be endoexcision surgeons, and often on pathology, there's perhaps 1 biopsy or 2, and then when we read the operative report, the rest of the pelvis is ablated. So please do your homework about your surgeon. And as we all know, ablation does not work. Excision is really the gold standard of care. And for those of you who need some help with surgical decision-making, and if you're desirous of fertility, please don't let your physician rob you of your fertility organs. It breaks my heart when patients come into my office and they no longer have a uterus, perhaps they don't have ovaries, and now they're in worse pain than they were before, and their dream of a white picket fence and children has, really passed them by. So I want them to advocate for themselves. And if your doctor is recommending a hysterectomy, and maybe you've completed childbearing or you don't want to have children, I really want to make sure that your surgeon also excises endometriosis. It's so important because often surgeons will go in there and they'll do an intrafascial hysterectomy, which means they're just kind of going in and they're removing the uterus and they're leaving all the disease that's external to the uterus behind. And when I was part of filming the first movie of Endo What, Mary Lou Balawag had said, every patient needs to know her his or her disease better than their physician. And I think it's so important that we do know a lot and that we ask our surgeons, do you also treat other coexisting conditions? Because it's so important to address, these are just some of them, but the more common ones that I see: pelvic floor dysfunction, interstitial cystitis, anxiety, depression, SIBO, and central sensitization. The reason that's important is because sometimes these coexisting conditions can be responsible for, let's say, a fair percentage of one's disease. And if the surgeon finds, let's say, adenomyosis on imaging, we can't think that adeno is responsible for all of a patient's pain. So we don't want to treat a patient based on imaging. We want to spend our time in trying to figure out where pain is coming from so you get the right surgery to treat the right source of pain. And we do know that a multimodal pain approach does work. And I think it's so important, endometriosis, for all of you out there to understand, it's this inflammatory disorder. It's kind of, I love playing dominoes as a kid. It's like the first domino that then sets off a cascade of other things like pelvic floor dysfunction, central sensitization, for some interstitial cystitis. We're finding about 80% of SIBO in my practice, anxiety, depression, I can go on and on. So I really do believe that it's important to undo all of these generators and talk to your surgeon about helping you figure out whether you have any of these. And again, this is my goal, to really help you live your life to your fullest and pick up endo early on. And like I was saying, what Mary Lou Balawag's taught me is to know your disease. And I'm not trying to sell my books. I'm not trying to make people watch these movies. But what I hear from patient after patient is that your book was so validating. I had tears in my eyes. My mom now understands my disease. My spouse now understands my disease. So this way you have a whole team behind you. And same thing, so that you can advocate for yourself and like with your employer, so they can understand when you have pain. So thank you. I would love to talk for hours on this subject.
Thank you very much, Dr. Iris. Beautiful, beautiful, and meaningful addition. Okay, so we have another speaker for you coming right up. And do you have the clicker?
I have the clicker.
Good. Let's click to you.
Advance the clicker. Sorrel.
Sorrel.
Yeah.
Well, actually, no, I need mine to introduce you.
Oh, okay, but I don't have a title slide.
I have a title slide, good. So, why can't I?
To our friends at home, I need no introduction.
Thanks, I'm gonna make you go back and forth. Working out technical, perfect. Okay, next we have Dr. Sally Sorrell, and she will be speaking to you on collaboration between multidisciplinary medicine and therapies, a multifaceted approach to endometriosis care. Dr. Sorrell is a pelvic physical therapist. She was a pioneer in the field of pelvic floor physical therapy. She is also the person who, together with Andrea Vidali, started the Endo Summit. So, and I'm going to remind all the speakers that we have all these patients watching, and that's our portal. Okay. So that camera right there. Yay, okay. Dr. Sorrell.
I want to thank AAGL and Shanti and all of everybody who's been involved in creating this unique session, including everyone out there who's logged on to see today. These are very unique events to see us, patients and surgeons all together, so it's a privilege to be here today. I just wanted to take a few moments to talk to you about your pelvic floor, because what I'm passionate about is not only teaching about treating endometriosis, but about teaching you, the person with the disease, that all that drives pain in the person with endometriosis is not necessarily endometriosis. Endometriosis does this very unique thing in that as soon as you have pain or you have inflammation from the actual lesion of endometriosis, it sends a signal out in your body, and then the signal is recognized by the brain and comes back and spasms your pelvic floor. This happens within the first 3 months of having pain. So for those of you at home, think about, like, I didn't get help for 23 years. How many years for you? 25 years, so 3 months, I mean, forget it. So within that first 3 months, you're getting a spasm in your pelvic floor because the body was trying to protect you. And then, unfortunately, pain causes spasm, spasm causes pain causes spasms, it goes on and on and on. They only give me 5 minutes, so I can't keep going. So I want to just show you at home because you're going to get spasms from the pelvic floor, and there are 2 levels of the pelvic floor. Here you can see the superficial layer of the pelvic floor, and we typically think with endometriosis that pain from sex happens further back. But if you have pain in the superficial layers of the pelvic floor, you're going to have pain at penetration. And I have really worked with practitioners to normalize asking, do you have pain from sex? Do you have pain at penetration? And do you have pain further back? And then I add this question, because if you're looking at these illustrations, I ask, if you have pain with bowel movements, does it hurt as the stool leaves? Because you can see in these pictures that there can be muscle spasms really around the anus, and then you can't get any stool out. So people automatically assume they have pain after excision while they missed bowel disease, but is it the floor that's causing that problem? So then this is the picture of the pelvic floor of the deeper layers of the pelvic floor. And there are muscles that run really all around the pelvis that attach onto your pubic bone that help control opening and closing of the urethra, and that really work with your hips, work with your feet as well. We're going to show that slide. And it's important to note that the bladder is the sensory driver of the pelvis. So all your information, your pain information, has to go through nerve roots S2, 3, and 4. And so your pelvic floor responds to your bladder. So if you're somebody who has constant urgency, frequency, possibly burning, you really could have spasms within the pelvic floor that are creating this signal-based loop to your bladder. And I think it should be mandatory that everybody should get pelvic PT after excision. I also believe in prehab very strictly. So I also want to point out that the body is a fascial system, all connected. And we're doing a lot of work with diaphragmatic endometriosis these days. But when you think about the diaphragm, you can see in these photos really how related to the deep muscles that this is. If you're having VATS or you're having diaphragmatic endometriosis excised, you need to see a therapist that can really work with your ribs. This is not your average pelvic physical therapist. This is typically someone seeing complex cases, probably seeing only endometriosis patients, that can teach your ribs to move again. And then I also want to point out, I love this photo for one reason, is that you can see the foot and how the chain goes all the way up in your pelvis. So when you see a pelvic PT, in order to stop the pain in your pelvis, oftentimes we're evaluating your feet. But then the other thing is when we work on the trigger points in your pelvis, patients often sit there and say, wow, my feet feel so relaxed. And I like to show this so you at home can see everything connected. And then I point this one out. I am not a neuropelviologist, but I like to show everybody that these are the nerve patterns in the body. These are the dermatones. Every pelvic PT should be doing a dermatome evaluation when you walk in, and everybody with endometriosis likes to assume that all their pain is driven by an organ, but you can see up by some of these nerves, you would assume that's ovary pain, but it actually, I don't know if I get a pointer. Oh, what happened? Okay. But you can see up by the nerves by the hip, those are the ilioinguinal nerve and the genital branch of the genitofemoral nerve. And you can aggravate those nerves without it actually being ovarian disease. And it becomes very frustrating that everybody walks in and I don't know if the camera will pick it up. They walk in and they go, my ovary hurts. And guess what, guys? That's a nerve. And we need to, and you may have a cyst, and you may have an endometrioma, and you may have disease inside that's pulling at those nerves. But we need to start looking at that body that the pelvic PTs can treat the fascia around the nerves. There are physiatrists that treat the nerves themselves, anesthesiologists as well. And we need to stop assuming your ovary hurts, let's cut it out. Because when you look at this, you can really see that we can approach the body in a different way. I don't have a timer, so I don't know. I'm close. Okay. I just want to point out, if you come to our practices, sometimes we usually do this manually. You can see in the small photo that sometimes people want to know what goes on internally. I thought I would show the photo since I had it. And then also we're oftentimes doing myofascial release. But as you can see in this photo, as we end, endometriosis and myofascial disease or disorders rather, our whole body. So going to pelvic PT is not just about me using a figure to manually work something inside. Oftentimes I'm working in the ribs, I'm working the diaphragm, I'm working the feet, I'm working the pelvis, the sacrum. And so even if you're afraid of someone doing internal work, there is a ton of benefit to doing pelvic PT. So again, I want to just props to Shanti for putting this all together, and thank you at home for watching.
Thank you, Sally. Incredible as always. Thank you. Okay. Excellent. Our next speaker, we had in the program that Dr. Umberto would be speaking, and he is not one of our speakers. Our next speaker, doing patient empowerment, how to speak with your endometriosis surgeon and manage expectations for surgery, is Danielle Luciano. She is a professor of OBGYN and director of the MIGS division at the University of Connecticut. She is also co-director of the Connecticut EndoRise Endometriosis Awareness and Research Program. She also has a lot of awards we're not listing here today, but she's really our academic representation, so please welcome Danielle Luciano. And there you go. Thank you so much.
Thanks.
He'll switch, and that's your clicker.
Okay, perfect. All right. Thank you, Shanti, for having me. And this is such an incredible experience to be able to speak to all of you guys and to be a part of something like this. So I talk about the management of endometriosis as a team sport. And we had Dr. Karen Orbach talk to us about how she wants you as a patient to speak to the surgeon. I want to turn it around, and I want to talk about what the surgeon is thinking when the patient's coming to the office. Because part of understanding what questions to ask is also understanding what answers we want from you to try to help us to take good care of you. So if you look up, I Googled for 5 seconds, how to speak to your endometriosis surgeon. There's a million images, there's a million websites, there's a million PDFs about how you should speak to me as a surgeon. I want to talk about what the surgeon is thinking when he or she is planning your surgery, and then what questions do I want you to ask me to make sure that we are on the same page and we're managing expectations for the surgery. So what am I thinking? So usually by the time, unfortunately, you guys come to see an excision specialist, it's been years. And so I have this pile of information that you guys have brought. I have all the information in the story that you've told me. Sometimes I have some imaging, sometimes I have some previous operative reports. And so in my head, I'm already starting to think about what kind of surgery am I going to do? Am I going to be able to do this laparoscopically? Am I going to need the robot? Is this case going to need a laparotomy? Or an open procedure? What am I going to see when I get to the operating room? Is there maybe some bowel endo? Are there adhesions from your previous surgery? Did they leave some bladder endometriosis? Did they leave some diaphragm endometriosis? Do I need to consult another surgeon to be there? Do I need a thoracic surgeon? Do I need a colorectal surgeon? I also want to know what your fertility plans are. Now, I don't need to know exactly how many children you want to have and whether it's a white picket fence or a brown picket fence or whatever, but are you going to be doing IVF? And then in the back of my head, should you maybe see a fertility specialist before I do your surgery? Maybe you don't even know what you want to do fertility-wise. And when I do your exam, or I look at your imaging, or I look at your previous operative reports or pictures, I'm thinking, wow, this is a lot of damage to those ovaries. Maybe this patient should see a fertility specialist before I do surgery, or at least have a consult. And then, does this patient want complete excision? A lot of times they'll say, yes, I want everything out, but do you really want everything out? Even if it includes bowel endometriosis, even if it includes a hysterectomy. So these are the things that are in my head when you're telling me the story, and these are the things that I want you to be able to tell me. So I want you to tell me first, what are your symptoms? And most importantly, what bothers you the most? Is it always in one particular spot? Do you have pain with bowel movements? Do you have pain with urination? Do you have pain with movement? Do you have pain with sex? Where is it that it's bothering you? Or maybe you don't have any pain at all. Sometimes I have patients that come and see me from my REI specialist, and they swear they don't have any pain at all. They just have these big endometriomas they want me to take out before they do IVF. So I want to know what's going on. And this goes back to the fertility goals. Is one of your goals to have children in the future? And I'm not asking this question because I really want to know about your personal life, but I want to know, is that something that you want to do? Or is that something you just want to leave open and available? Would you consider fertility treatments? If you absolutely would never consider fertility treatments, and I saw a patient just like this a couple of weeks ago, she absolutely will not do IVF. She won't do it. She doesn't believe in it, she won't do it. That's important for me to know, because I'm not going to take your tubes out if you're never going to do that. Are you done with or not interested in childbearing? That's okay too. That may make a difference in how we do your surgery. Would you like to consult with a fertility specialist beforehand? A lot of my young patients, I had a young woman that was 20 years old with big endometriomas, and she never even had the thought of talking to a fertility specialist about preserving her eggs. No one had ever suggested that to her. That's one of the things that I want to know. And then extend to the surgery. What are your thoughts on complete excision? Obviously, I'm going to excise those lesions for you, but do you want my colorectal surgeon there? What if I do a resection and you might need a colostomy for a little while? Is that too much surgery? What about doing a hysterectomy or removing your ovaries? Or what happens if you really don't want any of those things and I leave that disease because you don't want a complete resection and you don't want me to touch your bowel, or you don't want me to touch your bladder, or you don't want me to touch your ovaries or your tubes? What's that going to happen when I don't do those things? What can you expect after the surgery? And that goes to the expectations from the surgery. You want to ask me, and we want to talk about your recovery time. We want to talk about follow-up. We want to talk about when or if you want to try to conceive. We want to talk about what symptoms may not get better if I don't resect all that endo. I had a patient recently, again, who had a big piece of bowel endo, and she really, after seeing the colorectal surgeon, did not want the risk, even remotely, of needing a bowel surgery. So her question to me was, but what does that mean is going to happen to my symptoms if you don't remove it? That's an important conversation that we have to have before the surgery, not after the surgery when she comes to her post-op visit. Is there any medical management that we can maybe do to help with those symptoms? And then when can I return to work? They're always quick to be like, when can I return to work? When can I return to my normal activities? I need to know what your work and your normal activities are and what your boss or your family life is going to tolerate. And I can also then tell you who you need to have around to help you. So taking it again as a team sport, tell your surgeon what you want from the surgery. Ask all the questions, even the ones that you think are silly. They're not silly. And tell me what you're thinking. Tell me what's going on in your head, because I could be thinking something totally different than what you're thinking. And then why we're doing this. Check out the support groups, the advocacy sites, talk to your friends, go online, get more information about what to expect, and find out other questions that maybe you didn't even think of asking that they'll be able to help you think of. And that's it.
That was fantastic. Thank you so much, Danielle. All right, we have another speaker coming right up for you. And this speaker is really actually has become very dear to my heart. Believe it or not, I met him first on social media and saw what incredible work he was doing. So I want you to meet Dr. Ramiro Cabrera, also goes by Ram Cabrera, coming to us from Mexico, where he is Director of Reproductive Surgery of the Mexican Association of Reproductive Medicine and Surgical Director of the Doyenne Institute. He is an expert in, that's okay, in surgery for deep endometriosis. Okay.
Oh, thank you.
And he has your slides.
Oh, then perfect.
So you use that.
Perfect. So thank you very much. First of all, I'm honored to be here representing all the Mexican society and one of the best groups that we have, the Endolatam. By shame, I only have 5 minutes. So I try to put everything we're doing worldwide for endometriosis patients in Latin America. So I'm one of the head representatives of Endolatam and also a head surgeon in the global group. So what we're trying to avoid is what you're seeing right here. Right now, I have been all over the world trying to help patients, even from India, and we have seen the same picture everywhere. There are patients that are misdiagnosed and mistreated. We already know that, that's why we're here. But the problem is that many of these patients have problems with their lives. As many of them, they're misdiagnosed. They sometimes end up in the psychiatry room, and by obvious reasons, they have endometriosis and no one believes them. So we have to change this, and this is the main thing that we have to understand. There are over 200 million women affected by endometriosis, 1 in each 10. And remember, that incidence was before the endometriosis mapping that we can offer patients now. We can diagnose deep endometriosis by imaging studies, something that my father and grandfather wasn't able to do. Remember that. So probably the incidence 1 in each 10, it can be more. So we have over 200 million women affected, and we have to change our way of thinking, because this picture is something that's representing worldwide and is repeating themselves all the time. Many patients go and they search for help as soon as they start their menses, and many of the primary physicians, even in first world countries, they go to a general practitioner first, and then they start misdiagnosis, and they take up to 10 years. In Mexico, some people die without diagnosis. So we have to change that, because even some of them, they go under surgery without mapping, and then severe damage comes, and then you start having the central sensibilization and also chronic pelvic pain and infertility that we can avoid if we can get diagnosed our patients earlier, as well as we can avoid chronic damage by even surgeries. That's something that we should first change. Well, by obvious reasons, we already know that the definition of endometriosis has changed over the years. It's not the same tissue as the endometrial tissue. It's endometrial-like tissue that wherever it affects, it causes systemic dysfunction of the organ affected. So that's something that's why I'm here to explain you something about what's deep endometriosis in the bowel. So the most important part that we're trying to avoid, and I have to change, is this. We already know that endometriosis comes in the peritoneal way that can be diagnosed and should be treated at the same moment of a diagnosis laparoscopy. But what we call now the high-quality diagnosis is that before going into any surgery, you have to go under endometriosis mapping. That means that we can diagnose deep endometriosis in any organ affected, and obviously ovarian endometrioma. So high-quality diagnosis is something that any patient with deep endometriosis or endometriosis suspected should ask for. So what high-quality diagnosis? That before going to surgery, we go to a World Health Center for deep endometriosis, we do a mapping. With a mapping, expert radiologists can help us through MRI and ultrasound. In my center, we do both, so we can increase sensibility and specificity. And with this algorithm, doctors like Chamier, Luciana Chamier, that was brought by the radiology group in the US, start getting the mapping correct protocol. So now the endometriosis experts for radiology can diagnose deep endometriosis in the bowel, and with this we enter to surgery beforehand already know the disease. Why? My father and grandfather used to believe that the only way to diagnose endometriosis was to diagnose laparoscopy, but the human eye cannot see through tissue. So if we enter and we see a frozen pelvis, I will let now $1 million to anyone to tell me what was the size of that nodule right there in the bowel. No one can know, because the human eye cannot see through tissue. So we can see the nodule and see the length of the nodule as well as the involvement in the bowel before going to surgery. Now, many patients worldwide has been misdiagnosed with irritable bowel syndrome. Why? Because it resembles the same symptoms as deep endometriosis in the bowel. And remember that 1 in each 10 women are suffering from endometriosis, and you have peritoneal disease in the hypogastric nerve in the bowel, or even deep endometriosis, you will have the same symptomatology as IBS. The difference is so easy as ask the patient and hear them if the symptomatology enhanced during menses. If it's enhanced during menses, it's more probably that it's deep endometriosis in the bowel, that IBS. And you can have both by shame. So this is really important, but the most important part, if you have this type of symptomatology, you have to ask for your primary physician to give you an NCN score, and then before going to surgery, know the amount of disease that you have, and with this, we can even choose what we have to do. As now all the professors are telling, we have to change the way of thinking of just getting you into surgery. You have to choose what we're going to do. If you don't want to get a bowel resection, okay, you don't have to, but you have to know the amount of disease. We have even developed new techniques for taking this type of surgery. By shame, I cannot show you this, but this is really important because with this, many patients can be sensibilized that it's not IBS. And many of these women may suffer for deep endometriosis in blood, pain during defecation, and even diarrhea constipation. So this is really important. And sometimes cases can get really hard, and this is why mandatory before going to surgery, you need a colorectal surgeon or a pelvic expert in cases like myself that I have to develop full surgery so we can help this. Second thing, just to finish, because I only have 5 minutes, please, if anyone ever do you a colonoscopy and tell you that you don't have endometriosis, you have to tell them about this. Only less than 5% can be shown because it's extrinsic. It came from up to down. So in colonoscopies, we cannot see it. Less than 5% can be negative. And also this is really important because many doctors do believe that if they have a normal colonoscopy, you don't have deep endometriosis in the bowel. But by finishing, By finishing, we already know that correct excision therapy may enhance the quality of life of women and also fertility rates. So please, if someone tells you that they're going to do ablation, remember that ablation will never take away the tissue, and that's not recurrence, that's persistence of the disease. So we have to change that as well. Right now, the US have a burden of, say, $78 billion per year in correct treatment for deep endometriosis. So we can get to someone that understands this, and can change even that, you get less amount of billions of dollars in direct cost that is going on. So life begins when pain ends, and thank you very much. I think that this was really good, so a patient can understand better the quality of treatment. Thank you.
Thank you, Ram. That was great. Okay, everyone, we have one last speaker today, and that is a person who's very dear to my heart, Dr. Robert Furr, Scott Furr, as we affectionately call him, and he will be Zooming. There he is, great, okay. So he taught me how to do excision surgery during my fellowship at University of Tennessee in Chattanooga. So I owe so much to this man who really has been pioneering and working in excision surgery for many, many years. And so I'll let him take it over from here.
Thank you, Shanti. Can you guys hear me okay?
Yeah.
So, Shanti, I really appreciate you putting all this together. It's been wonderful, and the panel, you couldn't get a better panel. And so I hope everyone out there really understands what a dynamic group that you've put together, and it's been an excellent presentation. So I don't really have any slides. Unfortunately, about 2 weeks ago, I was supposed to be there with you guys today, but about 2 weeks ago, I crushed my tibia, and so they wouldn't let me fly to New Orleans. So I'm having to do this from my office. And basically, I wanted to just talk about a couple of things. One is this whole concept of access and getting to the right people. And I think the biggest barrier is actually us. It's the OBGYN community, and it's lack of understanding of the disease, and where that comes from. And I always say it's very unfortunate that the biggest barrier is really the OBGYN community, because it starts with just not being properly educated during residency training. And there are so few expert endometriosis surgeons out there that unfortunately we haven't been able to train as adequately as we would like to. And so this leads to, I think, a significant amount of ignorance in the OBGYN community about the disease. And that's what leads to a generalist OBGYN thinking that they can do endometriosis surgery themselves when they really should be referring out. And they're really quick to refer out to REI for fertility issues, or MFM if it looks like it's a dangerous pregnancy. But for some reason, there's this sort of lack of enthusiasm about referring to an endometriosis excision specialist. And part of that has to do with just, like I said, poor education, and the other part of it has to do with the generalists not knowing what's available in their communities. And so I think it's important for all of us out there who are specialists in endometriosis excision surgery to really get out in your community and have good relationships with the local OBGYNs, and let them know that you're there for them. You're not there to steal their patients, that you'll take care of their patients' problems and send them back. And I just have countless stories of people that come that have had 8 or 9 ablation surgeries with the same surgeon, sometimes as often as every 6 months. They end up having a hysterectomy, their ovaries out by the time they're 20. They're still having pain, and eventually they get sent to me. And unfortunately, I have to give them the sad news that I've always been in town, and this could have been prevented. And instead of a symbiotic relationship, it ends up that the patient becomes very upset with their primary doctor when it could have been much different. And so that's something that I think that all of us need to be more aware of, is to get out and educate our local providers and let them know that we're here, we're available, and that there's no need for patients to undergo unnecessary procedures that may end up destroying a good relationship with the patient. So that's one thing. And then the second thing is the what we do ourselves. And I think we've had some very, very good presentations. And what I do personally is some people will come in with these pages of notes and all these things, and that's great, and I think it's very important. But I usually start the conversation with telling the patient that I'm not a very paternalistic doctor. I'm not going to tell them what to do. I'm going to give them the facts and let them decide ultimately where we want to go with conservative management or surgery. And maybe I'm old school, but I think the history is really the key to everything. And so I basically start with, my first question is always, how old were you when you first started having periods? And then we just go from there. And it may be a 30-minute conversation, or it may be an hour conversation, but I think it's important for all the specialists out there to really set aside a good amount of time in your schedule for every patient. Every new patient of mine gets an hour for consultation minimum, and we start at the beginning and go from there. And then the plan develops for the surgery from that point. And I think you can gain a lot of things from the history itself. If they've got pain going down their legs during the period, they've probably got endometriosis, in the presacral area. If they have, painful bowel movements, then you know that you're going to find endometriosis either on the posterior vaginal wall, cul-de-sac, or the rectal vault, or in the pararectal fossa. So if you're a good old-fashioned country doctor and you don't have access to all of the imaging techniques, you can really gain a lot by just talking to the patient. And thirdly, I think it's important for us to follow the data, and that means, you know, what should be done at every surgery. And if you look at the data that's out there, everybody with endometriosis, and some of you might find this controversial, but the data's there. Everybody with endometriosis should have an appendectomy. Everybody with endometriosis now, based on Miller's study from April of 2020, should have a presacral neurectomy. And I know that's very controversial, but the data now is out there. And what I found, and we're researching this now regarding the presacral neurectomy with a prospective trial, but I have found that doing that in every patient has led to better outcomes, especially in those that have adenomyosis and want to preserve their uterus. And the final thing that I want to talk about is pudendal neuralgia. I think this is one of those things that gets overlooked, and I'm sure Sally is very in tune with this as well. But I think more and more, particularly with the deep infiltrative fibrotic endometriosis, we're seeing a lot more patients with pudendal neuralgia as a result of scar tissue formation around the pudendal nerve. And I think that's something that we all need to be very conscientious of when we're interviewing our patients and asking about symptoms.
Okay, thank you so much, Scott Furr.
That's all I've got, Shanti.
I appreciate it. Yay.
And I'm very proud of you.
Thanks. Thank you for, thanks for, you know, he is laid up with his leg in pins, and so he rose to the occasion, so thank you. Okay, so I think we can maybe on one screen put our panelists, and I'm going to go through a series of questions, and we're going to be short of time, so our answers are going to be shorter, and I apologize. Boy, we could talk 3 hours on this at least. But our first panelist I'm going to direct a question to will be Katie Boyce. She's a board-certified patient advocate, and you can read about her, I think, in the description that is online. What I did is we had a whole lot of questions, and I culled some of the salient ones that were most applicable and were echoed throughout some of those questions. So, Katie, I would love for you to address and talk about the psychological follow-up for patients with endometriosis following surgical treatment.
Hi, can you hear me?
Can you see us? Great, we can see you.
Okay, perfect. So I guess I could approach this from a patient advocate standpoint. So say, you know, somebody's had surgery and maybe they need to have another surgery, or they're struggling with whether or not to have another surgery. So as a board certified patient advocate, of course, I don't give medical advice. That's not my role, but it is my job to sit with them and help them go through all of their available options. And we look through various types of data if that's necessary. And sometimes they just need an extra person to kind of take a little bit of the emotion out of it, because it's really draining. And even myself as a patient, I still will sometimes need somebody to go over, you know, what other options there might be, or just what I'm feeling post-op. I think that, you know, patients in general, I think, you know, after surgery, there's just a lot going on. And I know that for many of us, we have a fear that any pain that we feel after is going to be endometriosis again. So it's this constant, oh, I felt this, is my endometriosis back? And so, you know, then it's, do I rush back into surgery? So again, you know, I'm not a surgeon, I'm not their medical doctor, but from the patient advocate standpoint, that's something that we would sit down and discuss, and we would go through all of their available options.
Thank you. That's excellent. Let me see if we can pull my slides back up for a moment. Okay. Do I have LJ Johnson on there? I didn't see her. Okay. I'm going to direct my next question. We can come back if we see her on the screen next. I'm going to come back to her. And this is a complex question, and Shannon Cohn, I'd love for you to answer it, and you can take it in whatever way you want. But I think Shannon almost doesn't need an introduction, but I will say that she was the mind behind the creation of the movie Endo What, and below the belt. She's also has a JD degree. She is incredibly brilliant. I served on a foundation board with her, saw her wisdom. She is a stark, incredible advocate for endometriosis with lobbying and on and on. So without further ado, what can you say about patient access to care, and particularly we're talking about the United States, and what are your thoughts on that, Shannon?
Heather says there's an audio issue.
Oh, we heard there's an audio issue that they can't hear online. So let's go back online so we can see Shannon. Okay, we see Shannon. You're, I think, on mute, Shannon. There, great, okay.
Hi.
Excellent. Okay, did you hear my question?
No.
Oh,
I didn't.
okay. I introduced you, and I want you to talk about access to care. So many patients don't have out-of-network insurance. Some patients don't have insurance. Some patients have state Medicaid insurance, and have a really hard time getting excellent care. And I talked about your work with lobbying, and you've done. I also spoke about your movies and a lot of what you've done. So maybe you could speak to what the future holds, particularly with your vision and with the lobbying that you do.
Okay, yes, thank you. Thank you for having us, and it's an honor to be here. I mean, as so many already that are here today know, like, this is something that's been going on for many years. I mean, these conversations are maddening because they are on repeat in different ways. And I mean, it doesn't mean obviously that we're not moving forward, but it is so frustrating for all of us, on the patient and the provider side, to see things go, 2 steps forward, 1 step back. But I am heartened by the fact that there are so many passionate, informed, educated people, in the trenches working on this. I think it's going to take building bridges continuing building bridges among all stakeholders. And that means the provider community. I really appreciated what Dr. Furr said about making sure that the generalist OBGYN community, that's certainly a priority, to make sure that they're educated better and more likely to refer to specialists. That would be a huge hurdle overcome if we can do that. Very practical considerations as far as access to care. And like I said, yes, building bridges among stakeholders. And the first is, of course, in schools and with school nurses and frontline providers, and making sure that they have what they need to quickly recognize symptoms, and refer, young patients to specialists. And I'm going to stop there because I'm very aware of the time constraints. So
Oh, thank you, Shannon.
kind of about what you want to.
I mean, it's really, we got that question a lot, and I don't know that any of us can answer that question today, and it's an incredible problem. But I do know that the funding toward research and some of the work you're doing ultimately will circle back to help access to care. Okay, I'm gonna, instead of showing my slides of every one of the advocates' information, I'm gonna just keep moving forward. And my next question is for Heather Guidoni. And it's, I think it's okay. Because it's so hard to go back and forth, but, or maybe we still can. Okay, but anyway, I've got, for Heather, here's the question. Do endometriosis patients always experience severe period pain, or only those with bladder and bowel as the main symptom? This was one of the questions that was sent in, and Heather is a patient advocate through Center of Excellence in Endometriosis Center in Atlanta, Georgia, and she has worked for years in this industry and is really a brilliant mind behind this. So she gets this question.
Well, thank you. So the short answer is no. I mean, I think that endometriosis presents uniquely to everybody. And by that, I mean, you might have adolescents who initially present with painful periods. You may have older patients who never had a painful period a day in their life. and only find out that they have endometriosis because they went for something else and it was discovered incidentally. So I don't think that it's right or wise to sort of paint it with a broad brush. What I can say is that I think endometriosis patients, myself included, can attribute endometriosis to virtually every organ system impact. We can attribute the pain from the disease to varying areas of our body, not just menstrual cramps, not just bladder pain, not just bowel pain, not just thoracic pain. It is a systemic disease, and the impacts can be body-wide. So I would never say, you don't have endometriosis because you don't have X, or you definitely have endometriosis because you have Y. I think that, as Shannon and everyone else has said today, the effort really has to be, and people have heard me talk about this, bench to beltway to bedside. The more we research, the more we know, the more that the outcomes will improve. So it's really just about educating patients about some of the more common symptoms, but also believing them and trusting in their narrative. At all times, the patient is the expert in the room on their body. So taking their perspective, factoring in the clinical exams, and sort of doing the stepwise algorithm of tests and so forth can help direct toward answers. But I would never pigeonhole the disease and say, I don't have bladder pain, therefore I don't have endo. So I hope that, I could talk all day about it. I hope that kind of...
That's perfect. That's perfect.
Kind of gives you a little summary.
Thank you, Heather. That's great.
Thank you.
Yeah. Okay. So I'll just quickly show you Heather's access there. You can contact her through there. And our last question is going to be for Wendy Bingham, who we have here on stage. And so she will come on up here to the podium. Yeah, come on, girl. Wendy Bingham is a pelvic floor physical therapist, but she's currently working near me up in the Pacific Northwest, now more with her Foundation for Extra Pelvic Not Rare. So she's going to talk to us about how to determine if pelvic floor therapy is the right option for post-endometrial surgical pain. So what do you think? How do we determine if pelvic floor therapy is the right option for post-surgical pain?
So thank you, Dr. Moling. First off, I do want to clarify, she probably forgot, it's the end, she's done a lot of presentations. I am not a pelvic floor therapist. I am a neurology physical therapist, but I'm going to speak, this is a great answer, great question for me. If you have a question for pelvic floor specific, talk to the queen right over here, Dr. Sally Sorrell. But this is actually the perfect question for me. If you have endometriosis, which most people do, that's somewhere in the pelvis, the bowels, the bladder, it's, to me, very obvious. Yes, you should always have pelvic floor physical therapy. But here's the question. For someone like me who had upper abdominal was where my severe disease was, I actually had a pretty clean pelvis. Should I have had pelvic floor physical therapy? Yes, yes, and yes. Why? Because the body is intricately developed. You have the myofascial system running through your body, the pelvic floor muscles and the diaphragm and the latissimus dorsus, all these beautiful fancy named muscles all connect together, and it holds contents together in our body. Our body functions. The pelvic floor has more than 6 functions, and the diaphragm and the pelvic floor work together. I went through pelvic floor rehab after I had excision surgery, and I can tell you that you do get referral from the fascia, from the pelvic floor that can go up to the diaphragm, as well as the diaphragm referring down to the pelvic floor. So it's really important that the continuity of your entire body be addressed, and that includes pelvic floor physical therapy. And I also believe that a lot of women are told they have central sensitization. And as a physical therapist myself who've gone through it, I had a lot of central sensitization. It took me 2 years of on and off physical therapy where I reached plateaus to gradually progress and reduce the amount of stimulus that would set off symptoms so that I can then go back to functioning again. So I hope that answers the question. Yes, yes, and yes.
Perfect. That's perfect. Okay. Do we have time for one more question? Does everyone mind if we just go a few minutes over time? Because I saw LJ on the screen. So let me see. Let me go back just to LJ. And see if does she still look available? Okay, great. LJ, I hope you're out there. I want to ask if you would talk about dealing with endo and natural menopause after surgery. Hi.
Yeah, I think that's a really good question. Can you hear me okay?
Yeah, we can hear you perfectly.
I think the first thing is to realize that just because you're in menopause does not mean all of your symptoms are going to go away. And I think that's the biggest misconception, is that some people are just hoping and praying that they get to menopause and they're going to be good to go. And it's realizing that you are going to want to bring some hormones in. I think there's a lot of fear when it comes about bringing in hormones because of, misconceptions, different, birth controls that they've used, lack of knowledge, lack of education, different things like that, just the disparities that come in. So realizing that hormone replacement is very individualized. I think that's another thing, like as far as the misconceptions, many people feel like, what works for one will work for another. And it's realizing that everyone's body is very bio-individual, looking at your symptoms. And then also realizing that just because you have endometriosis and you go into menopause does not mean that you're going to have a lot of symptoms. I think it comes once again from social media and all the things we hear. We just think that if we have endometriosis, this is how it's going to be. I'm going to either suffer, I'm going to have this, I'm going to have that. And it's really like we've been saying, like realizing that everyone's body is very different and that you need to have a specific approach and having a team that is going to support you through that. But realizing that just because you go into menopause, may it be medically induced or just naturally progressing, it does not mean that all your symptoms are going to go away.
Perfect. That was a beautiful answer. I really appreciate that. I didn't see you earlier, so thank you for coming back on, LJ. That was a beautiful answer to that question. Okay.
Tommy, can I just add to that for a second?
Yes.
So, this is a really, really important thing, and I've actually been collecting data over the last 4 or 5 years. I started seeing patients that were having surgery for some other reason, whether it be pelvic floor prolapse surgery or whatnot. The average age of these people, and I've got about 80 of them on the list right now, the average age is 62. They've all had, they're all either had hysterectomy and ovaries removed or were surgically menopausal. And I found active endometriosis in these patients, and hopefully we'll be able to get some data out soon. But the point is, there's this huge misconception in the general community that taking the ovaries out and removing the uterus is a cure for endometriosis. It absolutely is not. And hopefully we can get this data out soon. But again, average age of the patient, 62, all menopausal, either surgically or naturally, and are finding active endometriosis lesions confirmed by pathology.
Thank you. That's, of course, a great point. Okay, I think we're out of time. And is Rosemary there? Did I have a question for Rosemary? Can you put my picture, I do. I also have Denny Shea, but we're out of time. Unless we can go, let me see the view of the Zoom view. We still have a lot of participants. Okay, I have 2 more questions. If people want to hang for 5 more minutes, okay. Kathy says yes. All right. Let me see. Okay, so I've got 2 more questions. Here we go. Rosemary Phillips. Is there anything a patient should be doing at home to better manage their endo symptoms? And you can read about Rosemary. I think they'll put it in the corner of the screen. Great. Okay, Rosemary.
That's a really big question because there's a lot of different ways to manage symptoms. I think honestly, the biggest thing is to listen to your body, to track what your symptoms are, and like really actually track them. And there's a lot of different tools that you can use to do that, but you can simply do it on your phone so that you can present all of the best information to your doctor. And, there's a whole list of ways that you can manage, some symptoms, to the best of your ability. And there's a free endo course that Kate and I had created that I believe is in my information. And there we've got symptom trackers and things like that I really highly recommend. I know we're over time.
I love it. I love it.
As brief as possible.
And I really think we need to have or add this to the Endo Summit or something. We could do several more days of these great questions and answers.
It could be an hour conversation. Yeah.
Yeah. Okay. So
but the biggest thing is really listening to your body and making sure that you're identifying it and and honoring it, because sometimes, you know, when we're not being listened to by providers or family members or friends, we tend to ignore them ourselves too.
I have a very similar question for Denny Shea, who is also here with us today, and she's early in starting her advocacy program, and just a very wise person. So I included her today. So I want you to hear her thoughts on alternative modalities that help the most in recovering from surgery. Okay, Denny Shea.
Thank you, Dr. Moling. So I would say there's a lot of alternative modalities out there, and, you know, try them all. See what works for you. See what you actually enjoy receiving. So if you're not someone that wants to meditate, don't meditate. If you're not someone that is, you know, naturally attracted to yoga, that's okay. There's many things from acupuncture, and I'm a big fan of body work as a massage therapist myself. So, you know, there's lots of different body therapies out there. And, you know, if access is challenging, there's a lot online that you can look for that are free, ways that you can downregulate your nervous system. So I would say in whatever way you can be engaged with your body, befriend your body, and find a bit of play and pleasure, even amidst like the pain and the discomfort that can be like an ongoing thing for most people. I highly encourage that. We could speak more about, you know, all the lists of different modalities, but it's really about being curious and open and willing to try things out until you find one or find a provider or practitioner that you feel safe with. Because being with someone you feel safe with, that co-regulation will be huge for your nervous system and really support you in starting to manage some of your symptoms outside of surgery. So I could say more, but I'll...
No, that's perfect. In fact, we could all use people we feel safe with to co-regulate and calm and be centered. And so it was a little bit frantic for me today to manage getting everyone together, my different PowerPoints and so I thank everyone for your patience with the technical aspects of this, but hopefully today you got at least a few pearls that will help you in your own path toward healing this incredibly debilitating disease. So thanks for the people who came here locally, and thanks to all of you out there online, and my advocates who came online. Thank you, and my incredible providers here. So go out there, enjoy a great evening, and I think all of us are available as you need. Great.